Good morning, everyone. I'm glad I'm on early, and I'm glad. So that means you all got coffee because there's no getting away from the fact this is really boring. It's as boring as the title suggests. But what I hope to be able to convince you over the next kind of 20 minutes is that this is, the outcome of this is really exciting, and you're going to hear lots of exciting things today about things that will change your outlook, whether it's screening or treatment or something, and that's great. That's why we're here. This is exciting, not really for any of you, but for all the thousands of people out there who might be shopping in Coventry this morning or taking their kids to football, who have Lynch and have no idea. And so that's what this is about. So, always start with problems, getting it going. Okay, so the basic fundamental, principle is that we know that Lynch is really common, 1 in 350 people. That means your average, hospital, wherever it is, even a small hospital, it's got 700 beds, will have maybe a couple of people in it at any one time with Lynch syndrome. They might not be there for cancer, and they might not know they've got it, but there'll be people in every hospital with Lynch syndrome, and every GP will probably have about 25 patients with Lynch syndrome. And again, they might not know they have it. So that's why, and again, we know about this, so I'm not going to dwell on it, but the National Health Institute of Health and Care Excellence put out these guidelines to suggest that all people with these two cancers, colorectal and endometrial, should be tested for Lynch syndrome. And again, you probably know this because this is quite old work, but Bowel Cancer UK did a survey looking at how commonly this guidance was adhered to, and in England it was only 17%, and lots of reasons cited, but funding and capacity and awareness all played a role. And more boring data, sorry, but the National Bowel Cancer Audit, which looked, so this is annual, but looked from for the 2018 to 19 data, and they reported in 2020, found that only around 2/3 of trusts were looking at mismatch repair, which is the hallmark of Lynch syndrome cancers. Well, you might think, well, that's not too bad, 2/3. But if you look at how consistent they were, only 12%, 1 in 9 were doing it in more than 70% of patients. So, really not good enough. And more boring data, but if we look at colorectal, so NDRS is the National Disease Registration Service. We have representatives from them here today. There, Fiona, who will talk to you, I'm sure. And they produce amazing data through cancer outcomes. Every cancer diagnosis is notifiable. And what this shows is that, around 35,000 cases of colon cancer every year. It's quite a lot, isn't it? But, probably 6% of those should be getting a test for Lynch syndrome, and it's crept up a bit over the years, but it's still too low. And endometrial cancer, a bit less common, but maybe 8,000 cases a year. Again, about 6% of those should be getting a Lynch test, and again, it's only 1.5%, so not enough. And I'm not going to talk a lot about treatment because I'm a geneticist, not an oncologist, but this was a really important trial that was published in the New England Journal of Medicine, which is one of the biggest journals in the world for medicine, a few years ago now in 2020. But this shows how good this new class of drugs, which we tend to call immunotherapies, this is on pembrolizumab, how effective this can be for treating disseminated, what we call metastatic advanced colon cancer. And this isn't specifically in Lynch syndrome patients, but it's for the type of cancer they get. And this is your what's called progression-free survival. So how long you have before the disease progresses. And if you get standard chemotherapy, it's not great. progression after a couple of years, for the majority of patients, whereas if you give them pembrolizumab, around half of patients will get no progression for a really extended period of time. So I think we built, I've shown you there is a case for change. Only about 1 in 20 people with Lynch syndrome know it. The rest are just going about their business at risk of cancer, and they are unaware. And we're not doing enough testing, so we're not going to find them unless we test them. We know that pembrolizumab and other drugs can be really effective in treating these cancers, and actually we don't have to wait till people get cancer. There's lots of things we can do before that to reduce the risk. We know Professor Sir John Byrne's work has shown that aspirin is really effective in reducing the long-term risk of cancer. We know that lifestyle factors play a role. So if you lose weight and stop smoking and change your diet, this can be really effective in reducing the risk. We can offer surgery, and we know surveillance plays a role in reducing that risk as well. So it's really important that people with Lynch syndrome know it. So for reasons I'll never fully understand, I was roped into leading this project with Dr. Monaghan, and we were tasked with trying to improve the diagnostic